In the next 5 minutes, we will discuss one strategy to help us manage distributive shock refractory to standard therapies. You have a patient in septic shock. You have volume resuscitated, have been titrating norepinephrine, and are ready to start vasopressin in accordance with current sepsis management standards. The patient fails to respond to standard therapy, and titrating medications to increase afterload and systemic vascular resistance isn't working. The great thing about the well-oiled machine known as the human body is that it has built-in mechanisms in which to compensate for hypotension and hypoperfusion. 2 of the 3 mechanisms we already tap into and have been clearly established from the perspective of current care standards. At this point, we are attempting to supplement the sympathetic nervous system and arginine vasopressin systems as best as we can. But what about the renin-angiotensin-aldosterone system? How does it even work to help manage blood pressure? Angiotensin II is the key. Synthesizing angiotensin II begins with the production of the pre-enzyme angiotensinogen in the liver. When the kidneys sense low volume and perfusion in the nephrons, they release renin to convert angiotensinogen into angiotensin I. Angiotensin I is converted to angiotensin II through the angiotensin-converting enzyme from the lungs. Angiotensin II influences vascular smooth muscle at the AT1 receptors. When stimulated, they cause the smooth muscle cells to contract and a subsequent influx of calcium. Vascular smooth muscle cell contraction leads to vasoconstriction and ultimately an increase in blood pressure. Angiotensin II also regulates blood pressure by regulating fluid and electrolyte balance in the kidneys. This is where the hormone directly acts on sodium transport, which is responsible for sodium and water reabsorption into the vasculature. The same thing occurs when angiotensin II stimulates the adrenal glands to stimulate aldosterone. This is the actual drug. Compared to a vial of norepinephrine or vasopressin, it is quite expensive, in the area of $1,600 per vial. So its decision for use is closely scrutinized. The use of this agent, as well as the management guidelines, are based upon the following study, described and outlined in the August 3rd of 2017 issue of the New England Journal of Medicine. To summarize, this was a double-blinded study in which 321 adults with a mean age of 64 years were in distributive shock. 91% had septic shock and the rest had other forms of distributive shock, refractory to standard therapy. There was a 1-to-1 randomization to either the drug or a placebo. Drug doses were titrated to achieve a mean arterial pressure of 75 or higher without titration of the initial vasopressors that the patient was started on. After hour 3, dosing of the initial vasopressors were titrated down and the study drug was titrated accordingly in order to maintain a mean arterial pressure between 65 and 70. At the time of study drug administration, 97% of the patients were on norepinephrine, 67% were on vasopressin, 15% were on phenylephrine, 13% were on epinephrine, and 2% were on dopamine. The vast majority were on at least 2 vasopressors, and almost half were on 3. The primary blood pressure end goal was attained in 70% of the study drug patients, while 23% of the placebo drug patients saw positive blood pressure results. The medication is mixed and diluted in normal saline per manufacturer recommendations, and we can dilute in various concentrations based on whether or not the patient is fluid restricted. The package insert provides valuable information related to indications, dilution, and dosing. In addition to these administration guidelines, there are very strict temperature control requirements that will actually require survival flight to utilize a portable cooler/refrigerator when we are transporting it to the patient's bedside. This medication was introduced into our formulary at Michigan Medicine last year with strict administration guidelines, including a clear indication for its initiation and whose consent and consult are needed to administer. Survival Flight anticipates implementation of this medication into its shock protocols in the near future and will adhere to these same guidelines. Currently, there are no recommendations for administration to anyone younger than the age of 18. While there are some subtle differences between our administration guidelines, they fall within the basic recommendations of the manufacturer. They are just a little bit more specific. Thank you.